Pattakos.
Thank you very much, Mai. I'm going to be really quick because we're cutting into the time for lunch, so I respect lunch. So we're going to show you a TAVR with the accurate system. This is an 80-year-old female with a BMI of 29, NYHA3, with severe aortic stenosis and the gradients you see there, EF of 65%, who had a coronary angiography with 50% RCA stenosis, rheumatoid arthritis, a couple comorbidities. She had peripheral artery disease with a 50% narrowing of the right common iliac, and STS risk score of 4.89. So we elected to proceed with TAVR with the accurate valve. The procedure you're going to see has a repeat coronary angiogram, which we do relatively liberally when it's either a previous CTA or the previous coronary angiogram is old. We use ProGlides, a 14 French eye sleeve, and you can see that the hemodynamics before and after improve, the gradient goes away. We do pre-dilation with Edwards balloon 20/40. This is recommended by Boston Scientific when using their valves. So the other two things to see for people who have not used this valve, and this valve is, we feel fortunate to be in Europe because this valve is not yet FDA approved. So it's not available for clinical use in the United States. You see these two markers there that you need to essentially position at the valve, at the annulus, and this is the most important part of the case. So this is what it should look like when you're done. And once you get to this part, shockingly in comparison to other TAVRs, you're done. This is a very easy procedure, almost shockingly so compared to other cases. I don't think I need to show you access here, but this is probably what you should not do. And what we've moved towards is doing ultrasound guided sticks. And I think that you do away with what you're about to see here, which is that Mike and I and Kostas are going to show you here. We're going to do a roadmap. So you see a femoral vein sheath going in, and then obviously you all know how to place sheaths, but for the cardiac surgeons in the room, I want to show you, because when I place the sheath for the femoral artery, there's a minor issue where the wire won't advance, and the important thing to learn here is don't persist. Okay, so that's the femoral vein sheath going in, and look what happens here with the wire, right? So the wire goes in at first and it meets obstruction. And a lot of people, surgeons at least, and I'm speaking when I was learning, would just insist, no, you wait for the wire to go easily. If the wire doesn't go easily, your needle is not in the vessel. So I'm sorry that we're dumbing it down here for the cardiologists and they're hearing things that they already know. But I think for the surgeons that are going to start doing TAVR, and I hope that there's going to be an increasing number, you're going to see things. And you're going to need to know the right way to do it, obviously. So here, Kostas and Adonis are doing a coronary angiogram in order to see that the patient truly does not have any coronary disease, which he does not. And then we're going to proceed to show the right coronary angiogram. I'd fast forward here, but it's just going to cause the whole video to have issues. It's going to cost us to have more time than we need. So the right coronary angiogram is also fine. You see that 50% stenosis there, and I'm sure there's a lot of people who would like to debate, is that 50, 40, 30, whatever it is. We didn't think that it was unnecessary. So this is the way we used to do the procedure, that we're not really doing it anymore. So we have an IMA catheter. You cross over from the right side. So here the left side is going to be the dominant side. So can we kill the audio, or is it just for me? Anyway, let's make sure there's no audio. So you just do a angiogram here, and we have runoff, and then we use this as a roadmap. It's very important, obviously, that where you're going to stick the femoral artery here. And I'll be honest with you, before I started doing these procedures, where we stick as surgeons in order to place an intra-aortic balloon pump or a femoral A-line, it's way too low, okay? So that's what I want to tell the surgeons. We usually stick in the superficial femoral artery, and you're going to get more complications if that's where you're sticking. You want to be in the common femoral artery, and you're going to think that you're in the belly when you first do this. So at this point, we just place the sheath, and I'm sorry, for the cardiologist, you're bored here because you're seeing things that you already know, but I think, part of this is for the cardiac surgeons in the room. We do an angiogram here. in order to see that, you can see I'm in the common femoral artery and not in the SFA. You see that it's well above the bifurcation when you pull the sheath so that it's not overlying the skin. You can see where it is, and I think that's important. This is the placement of the proglides here. You use two proglides, obviously, 10 and 2 o'clock. Again, forgive me, the majority of you are hearing things that you already know, but I think it's important that this conference be a springboard for people who are not involved to become involved, because this is really not all that complicated. Yesterday, Dr. Kapadi, I believe, showed a TAVR that they did in 28 minutes. So I think there's going to be a lot of impetus for cardiac surgeons to go away from doing the 3, 4, 5 hour AVR to doing a TAVR. So at this point, we place 2 proglides. Obviously, for the sake of time, I'm only going to show you one, and soon we're going to get to the valve implantation too. And Mr. Konstantinos Fotinos is nice enough from Boston Scientific to be here. Some of you have not seen the valve, so we have the valve here if you want to see it. We have our angiogram, our root shot, root angiography, in order to give us the proper angle where we want to be working. This is the eye sleeve, the Boston Scientific 14 French eye sleeve that's being advanced. I think what's important for the surgeons especially to note here is that you can see the calcium, right? So look, this is like an x-ray, you see it, it's essentially like bone around the vessel, and pay attention and see that as the sheath is being advanced, the whole thing is moving, right? So that's where you need to be careful. This is where you cause your perforations. This is where you get your iliac on a stick souvlaki, and you basically have the iliac come out and you say, look what I found fishing. So that's really what you want to avoid, and you want to be mindful of this. And when you have a lot of calcification, obviously you don't even need contrast to see what's going on. We're going to place a temporary pacing lead here, and I leave it here to partially to show that, you know, all of us struggle with this. Sometimes everybody's right atrial anatomy is different, and so you know, if you're a surgeon, you try this the first time and it takes you more than 30 seconds, and you feel bad, don't feel bad. It happens to all of us. The other way to do it is just to pace through the wire that you're going to have in the left ventricle itself, but I think that's a little bit less reliable. So the next step here at this point is to have a AL2 catheter and a straight wire. And so at this point, the nice trick that Kostas was nice enough to teach me is that you basically want to put the catheter where the jet is going to be hitting you until you get that rocking motion of the catheter. Then you know that you're in the right plane. So you advance the wire in, and at this point you have the AL catheter sitting in the left ventricle. At this point, you're going to put in a J wire so that you can do an exchange to a pigtail. Some people will skip this step, but I think it's dangerous to put a stiff wire in with that AL. So you want a pigtail. And notice how here, if you can envision it, the J wire is hugging the outer curve of the aorta. That's where you want it to be. And the pigtail, for your reference, is sitting at the base of the annulus in the non-coronary cusp. So here now you have your pigtail, which is the second to last step. So once you have your pigtail and the LV, you can advance your stiff wire. In this case, it's a safari wire. With some of the procedures, we'll do a confida wire, but both work equally well. With the Boston Scientific valves, we do that. Here you see the valve that's being prepared. It's a little dysynchronous here because if you notice to the right, I cheated and rewinded, and so the wire's not in there anymore. But at this point, we're going to get ready to bring the valve forward. Do you want to bring up the valve, and I'll do my best to synchronize. So the first thing we're doing here is the balloon valvuloplasty. So we do a balloon valvuloplasty here that's recommended by the company, and you can see the 2 markers on the balloon. And here I'm just replaying it because I think you can see that white stripe on either side as the contrast goes in. Those are the leaflets that have been raised that obviously take the place of any contrast that would go there. So for the surgeons, look at that white stripe and notice that those are your aortic valve leaflets. So this is the valve coming into position. So you notice that all the time we try to not lose sight of the wire, okay? So the wire is in the LV, and it's very important. That's how mistakes happen when you're not looking at something, you're focusing on something else, right? Now we have the valve that's coming up, but it's important to focus on the wire. There's somebody always managing that wire. And as you notice at this point, Kostas is advancing the valve. but we're making sure that everything is remaining perfectly still. And so I think 90% of the work for this valve is just to see those dots, which I showed you before in magnification, because it's kind of hard to see now as you notice, and you can zoom in and do a variety of things, but you want to notice what's going on here and where you're going to position them, because once you have them in place, there's two knobs on this, and so once you're at the right position, you can bring in a high school student or my 8-year-old son to turn the knobs, because really that's all there is. Once you have it accurately positioned, it's a matter of turning the knobs, and anybody can turn these knobs. Really, all the science lies in getting to this step where you have the valve exactly where you want it to be. So at this point you can see it. Obviously you use Cine to be able to see things more clearly, and so at this point you're turning knob number 1, and you may not be able to see it here, but it's retracting this plastic catheter. And so at this point, the upper stabilization bars, as you can see here, stabilization bars are coming out. And you can see the upper crowns here are coming as well. And then step number 2, which is the second knob, essentially, I'll show you here, is just releasing the bottom part. And that makes the valve pop out off the system. And you're about to see that here. That's what you have. And the procedure is done. So the bulk of the work, in contrast to other valves, is done at the level or almost above the level of the annulus. And then the second step is that the bottom part jumps into place. All I'm going to show you here is that we did put down the proglides, did an angiogram. You can see a very minimal stenosis, if I can be honest, and critique ourselves, that the proglides caused in the left femoral artery. And we're done, and I really thank you for your patience and for being here.